I'd like to talk about imaging, and oftentimes I get carried away. So Greg already said he will lean to the left when I have 2 minutes left. So and if you sleep or like snore or whatever, then I know it was too long. So I try to do my best not to talk too long, but I'm very excited about the imaging topic because it really shows you, I mean literally shows you information about the patient as a doctor, and also the patient, because I have learned that when I show things on imaging to my patients, they oftentimes understand more because, yeah, you can really see something. So general information about imaging and what we do with imaging. We have to differentiate between the bone and the bone marrow, and this comes up again and again and again in my talk, bone and bone marrow. The bone marrow is actually the place where the disease takes place, where the plasma cells sit, right? They have there their niches and they are nurtured by the other cells around them, and this is where they belong and where they also sit. But the disease, the symptoms of the disease oftentimes are going on in the bone. 80 to 90% of myeloma patients have bone disease, meaning the bone is impaired in one or the other way by the disease or by the overactivation of the so-called osteoclasts, which are cells that are involved in the turnover of the bone. We think we are sitting here and our bone is not really caring about anything because it's dead. That's not true. The bone is turned over and over again, very slowly of course, and the older we get, the more slow, but the more so slow, you know, and so it's important to see that, and the myeloma causes this turnover to like way to the wrong side, like losing bone is what a lot of you I think have experienced. So important, bone marrow versus bone. Why is that important? Because we have different imaging techniques. X-ray, skeletal survey, you know, computed tomography, which is another development. X-ray is when a beam goes through the body from one end to the other, and then we have a film, or nowadays we have a digital scanner where we can measure what's coming out of there. And the denser a tissue is, the less radiation comes to the film or to the detector. And that's the concept of the X-ray, and the CT is the next development, where you don't have just one layer where you go, but the scanner and the detector go around the patient or the person that's in the scanner. So you have you're looking from every angle into the body. So this is very good for bone because the radiation gets weakened by the beam, gets weakened by bone, by the mineralized bone, which is a lot of calcium. And so you don't need even a contrast agent to see very well what's going on in the bone, so the symptomatic part of the disease. But we also want to know what's going on in the bone marrow. You know, and we just discussed that bone marrow biopsy is something we all like. And I have to admit, I have done it, it was done to me 4 times. One time I was a doctoral student and needed the bone marrow. The next 3 times I needed the money because I was a medical school student. So I have 4 bone marrow biopsies. I know how it feels, and I think it's good because I know what I do to my patients. So I have much more done myself. So it can be good about that. So bone marrow, we can do this biopsy, but it's a very small biopsy, obviously. I mean, we put a needle in there, and what we get out is really not much. So we want to know more, and you can see here those different techniques, and I will talk about all of them, show you much more bone marrow. Of course, not in this resolution, like when you put it under a microscope, but still you have an information on the bone and on the distribution of the plasma cells. I will show you more about that. So those techniques show you the bone marrow, but we can also get functional information, not only the so-called morphologic information, what is there at a certain time point, but also what is going on, what changes over time, what processes are going on in there. So we have several information, or we get information out of the different techniques. Starting with X-ray, when I talk to doctors, I already got rid of X-ray, but since I know a lot of you get still skeletal survey, I talk about X-ray, skeletal survey, what you can see here, where you still have this kind of older technique, where you have this one layer of information. It's widely available, that's the reason why we use it. It's rather cheap, and it was the basis of our guidelines several years ago. we said if there is a change in X-ray, then we have symptomatic disease. So the so-called CREB criteria, I think you've heard about that, incorporated this imaging by skeletal survey. It has a rather low radiation dose. Nowadays, we don't need too high radiation. In the early days, when Konrad Röntgen in Germany developed that, it was very high radiation, and I think a lot of people really suffered later from the results of their first initial trials. But nowadays, it's a really low radiation dose. Very important, it has disadvantages. This is very low sensitive. I will show you why I say that. And it is a rather long examination time. You have to move your limbs. Sometimes you already have back pain, so it's not really nice to have this examination. It's not really comfortable because you have to move, and it takes some time. And this is a study, a rather old study, where they looked what is the sensitivity of skeletal survey, of X-ray. So they took the spine of the corpse, that's what you can see here, and they drilled holes into the spinal, in the vertebral bodies. And they found that you have to destroy, it depends on where you are, to destroy about 30 to 70% of bone until you see something in X-ray. And I think that's definitely too late, right? So this is, we know that for a long time. At that time, they didn't have anything else. But nowadays, we have the option of the so-called computed tomography, which has, of course, a little bit higher radiation dose, but also gives you much more information. The advantages, it's much superior to X-ray. We did a study, and I will show you the results of that study, comparing X-ray and CT at the same time point. Mostly it was an X-ray and a PET-CT, what the patients got. And we compared, first the radiologist looked at the X-ray, and then without knowing about which patient it was, they looked at the CT. And we found that it's much better, and I will show you why. But the radiologists asked me, why do we do this study? It's obvious. But we hematologists are more conservative on that end, and we were used to the skeletal survey, and still today people try to argue with me, why do we do this CT? We don't need it. And I think the whole problem is they are not get built for it. So we are working on that, and I think that CT should be the new standard. We have low-dose protocols, which are not that much higher in a radiation dose. It gives you a so-called 3D information because the beam goes around the body, and you can see here, this is just one layer we see, but we have a lot of layers behind that where we can see, and the computer can calculate 3D images. You get much more information where the osteolysis is in a certain area of the body. So if it's, for example, in the arm, you can see that there's in which part of the arm the destruction really happens. It's very convenient. You have to lie down, go into the scanner, and go out. It takes about 5 minutes all in all. So that's really convenient and much easier than a skeletal survey. Nowadays, we are allowed to treat patients if they have changes in CT. This was really, I had a lot of discussions with colleagues saying, yeah, we see something in CT, but maybe we treat too early. But nowadays, I think we have learned that too early in this area, because, I mean, there is no too early if there is destruction of the bone. We should not wait until the destruction is like 50 to 70%, right? So this is what I would recommend. It is of prognostic significance. We know that if we have changes in CT, it really correlates to a progression into more aggressive and more symptomatic disease. Disadvantage is the little bit higher radiation dose, so it's about 2 times the skeletal survey. We are just in the process of writing new guidelines on that, both on CT and on the whole imaging topic, and we see that there are protocols which are really okay, and 2 times the radiation dose is, I think, okay because we don't have to do it that often. For skeletal survey, I would recommend to do it once a year because it's so insensitive. You have to look more often. But if you have a CT, you have such a good information about the whole skeletal system that you don't have to repeat it that often. So every other year or even longer time periods, if you're in a complete response, for example, then that's okay. Lower sensitivity for the bone marrow, but I will show you what we can do with that. So this is what we have as a so-called whole body low-dose CT. You can see we move through the whole body. This was the head, now the shoulders, the lungs, And here the spine, which is very important obviously for stability, and you get information on the back part of the spine, which is very important because there is the nerves coming from the brain to the body, and if there is something going on, it's very dangerous for the patient, and so you can go down there. Actually, most of the time it's not really a whole body, but a whole body until the lower parts of the thighs. Which is okay because there's very, very rarely something below the knees. So we can do that, and it's, as I said, about 3 to 5 minutes, very convenient for the patient. This is comparison, and we saw that if you are negative in skeletal survey, that's conventional skeletal survey, negative, you can still have positivity, meaning osteolysis in CT, so we miss about 25% of patients. They were considered negative in skeletal survey, and when we looked at the CT, we found that they were positive, they already had osteolytic lesions. And where are those osteolysis? There are theories that the plasma cells feel well where they are in the niche, as I mentioned, of the bone marrow, where there is usually bone marrow, and in us adults, mostly the pelvis and the spine, also the sternum and part of the skull, contains blood-forming bone marrow, which it's the organ that forms the blood, and so there are also the most osteolysis. So we think there's a correlation that those cells really feel well in this area that they know. But you can also have, of course, in other parts of the body osteolysis, but the most of them are there. Coming to the bone marrow imaging. Magnetic resonance imaging is a technique that is just relying on the fact that our body contains water in different percentages of the tissue. You have tissues with a lot of water and you have tissues with not so much water. And this technique can, without any irradiation, differentiate between high and low water or high and low fat content, which is the contrary of water for this technique. And this is very good to see the soft tissue part of the bone of the body, and that's in part it's the bone marrow. So you can see infiltration of the bone marrow, as I mentioned, where the disease takes place before the bone is destroyed. If we do a skeletal survey or even a CT, it might be that we only see changes when the bone is already destroyed, but we want, especially in patients with MGUS and smoldering myeloma, we want to see what's going on in the bone marrow, and we don't want to do, and I think you too, don't want to have a bone marrow biopsy like before and after meals. So we have something that we, a little bit exaggerating, but still, we want to do that not too often. It has the highest resolution for the soft tissue part and the bone marrow, so we can really look into the bone marrow on a larger scale. It helps, and I will show you an image for that, to differentiate to a certain degree between a benign fracture, which might occur when we get older, we get osteoporosis, versus a malignant fracture, which might be caused, for example, by multiple myeloma. So this is very important, and I also, we use that very often in clinic when we have a patient with MGUS and osteoporosis. We want to know, is the osteoporosis myeloma, defining myeloma because bone destruction, or is it just an MGUS and happens to have also an osteoporosis? It's relevant for follow-up. I also have images for that. We know that if we have residual changes in the bone marrow after therapy, it's not a complete remission yet, even though the serological markers might show that. It was incorporated in the new definition because we now know that those changes in the bone marrow might eventually lead to bone destruction. The disadvantage is that the bone itself is not very well displayed. So everything would be great if the MRI just would show the bone marrow, But because the bone does not contain too much water and too much fat, it's very difficult. It's just a black line where the bone should be. And so that's difficult for us. I mean, we still can do CT, of course, but so MRI is not the whole solution, but it has a high resolution and it shows us the bone marrow. Some patients with metallic implants, especially if they are older, might not be able to go into an MRI because it's a very high magnetic field and it might move some stuff that's metallic in the body. So this is very important to know, but the radiologists know that and would not let you go into the scanner with that. Last is the PET-CT, which is a very nice and very effective technique. The advantage is that it's based on the fact that malignant cells but also other cells have a high glucose turnover, meaning they need a lot of nutrition to keep up their high metabolism. And this is a radioactive sugar, basically, and this sugar is given into the vein, and then it's taken up by the, in this case, plasma cells, but also by other cells that are dividing and that are growing. So you can see where this lights up, and since the radiation is rather low and rather short, it's not a health issue too much, but it gives you information. You can see here this really bright yellow part. There's a lot of uptake. The problem is that not only malignant cells can light up, but also inflammatory cells, for example. So this is a challenge. So you see the metabolism, as I said, a functional part. It has a prognostic significance, so if you have a high uptake, it's worse, so the disease is more aggressive. It shows the activity of the disease, but it's kind of the same that as I just said. Disadvantages is, as I also mentioned, it might be false positive, meaning we see something but it's not malignant, and sometimes it's not easy depending on the area where you're doing the scan. It has a higher radiation dose because usually to see where those changes are, you put a CT on the background, so you have a very low dose CT plus the PET, so you have kind of a combination of this radiation dose, but still it's okay to use, and the radiation dose is not that big an issue because we get so much information out of it that we can't do it not too often, we don't have to do it too often. Okay, coming back to MRI, because it has this high sensitivity, it was the first technique where we found that myeloma is not always homogeneously in the bone marrow. When we do biopsy, we think that it's homogeneous because we do a biopsy at a certain point where it's easy to get, like here at the pelvis or at the sternum. There we get easy to our bone marrow. But the problem is that some patients don't have this diffuse infiltration, as you can see here. This darker grayscale means there is plasma cell infiltration. You can see here this part is lighter grayscale. This is a normal bone marrow, but here you can see this so-called focal lesion. That's an accumulation, like a small tumor in the bone marrow of plasma cells. And we stick needles in it, and there were plasma cells. And there were actually more plasma cells than in the pelvis of the same patient. We compared that, and we found that if you hit such a focal lesion, you find more plasma cells. So some patients have this pattern, and some have this, some have a combination, some have even only this normal-looking bone marrow, and we don't actually know where the plasma cells sit. They might be very active in the production of the monoclonal protein and the free light chains. It's also a rather old study where they looked if this focal or this diffuse is worse, and they found that the diffuse and the combined focal and diffuse has an adverse prognostic factor. It's not really changing anything, but it's good for us to know. But we see that the diffuse part also responds very well to therapy. So don't be too sad if you have this diffuse pattern in any report you find. It's also very well responding to therapy. And this is very old. This is the days when we just had melphalan. Okay. Treatment indication. As I mentioned, we can see the infiltration of the bone before the bone, the bone marrow, before the bone is destroyed. So we don't have to wait until we really have holes in the bone. This is a patient of mine with a smoldering multiple myeloma, and at that time I was in Heidelberg, and we had a lot of nice imaging toys. You see, I had a lot to play with. So we did a CT and we did an MRI. And this is the pelvis here. These are the femora. And same here, this is the bladder, which is very easy to see because it has a lot of water, as I mentioned, at least in this patient at that time point. And so just to orient where we are, so we are in this area here. Then we also looked nearer, and we didn't find anything. It looked normal, the bone, no destruction of the bone marrow looked also quite nice. So we repeated that because it was in a study, we repeated that after 6 months. And then we looked here, and we found this, it's another sequence. So in this case, this focal lesion is lighter grayscale. You can have two sequences, in one they are dark, in the other they are bright. And you can see here, this is this lesion. And then we looked back and found, okay, we missed this one. We said there are no lesions, but going back, knowing where this developed, we saw 6 months earlier there was already a small lesion. Then we looked, okay, there's something growing, that's not good usually, and we did a CT to see the bone, and actually there's the osteolysis that developed, which was not there 6 months ago. So we know now that if those focal lesions develop, if they grow, then they can develop into osteolytic, meaning bone-destroying lesions. And we found that if we have more than one of those focal lesions, it's already a sign. Those are all smoldering patients, you can see here. Every step down is one patient progressing into symptomatic disease, and we found that more than one of those focal lesions go along with progression into symptomatic disease. But we have to be very careful. If we have 1 or 2 or maybe 3 focal lesions and they stay the same over time, because we did sequential MRIs and we found patients with focal lesions, and then we followed up and we found some of them didn't change. So you don't have to treat a patient if it's just 1 or 2 focal lesions and if nothing else is going on there. But if they have focal lesions, either newly developed focal lesions over time, or if they have growing focal lesions, increasing in number and size, then it's an adverse prognostic factor. As you can see here, every step up in this case is a patient progressing into symptomatic disease. So every dynamic in this case is of a very, very significant prognostic factor. So we know if there's a change, like in the patient I just showed you, then we have to be very careful to follow up with this patient, maybe treat earlier than later. And this is not easy to see, but there are small b's and small a's and c's. These are the CRAB criteria of those patients we followed up, and we found all those with a red letter in this circle had a progression, and most of them, actually, you might not see that, but most of them had a progression with bone disease. So they developed, out of those osteolytic lesions, they developed a bone osteolytic lesion. So this is what we like to identify early and then hopefully prevent. This is an image to show you the difference between malignant and benign fractures. It's not very easy to see, but here it's a brighter one, which is myeloma. In this case, it's a darker one, which is osteoporosis. So just that you know, it helps to differentiate between, is it just MGUS and osteoporosis, or is it myeloma with osteoporotic changes. Treatment monitoring, we usually do free light chains and spike and stuff, you know that, but we can also do imaging follow-up, and this is a very good message for you. We are just in the process of looking into more patients with that. We did sequential CT at the first diagnosis. You can see here, this is a so-called osteolytic lesion, and this is after therapy, and you can see here this right margin, that's kind of a healing process. I was taught when I started to treat myeloma, I was taught there is no healing of osteolytic lesions. Nowadays we can say yes, there is. I have to admit we don't know which patients. We think patients who are treated well, of course. We think that the bisphosphonates have a good influence on that. We think that we have, with proteasome inhibitors, especially bortezomib, it has been shown that this activates the bone formation actually, and you can see in some patients kind of a process of healing. I cannot tell you that in like 2 years your osteolysis are all gone. That's not true, but at least we see some positive change over time. So we can monitor the bone disease. We can also monitor those focal lesions. These are the femora here. And you can see here, this is a big lesion, and after therapy, this is white because there's still an osteolytic lesion that will not heal in that short period of time. But you can see here, the lesion itself, the darker gray scale, is shrinking. So we see the benefit of the treatment. And we know that after therapy, if there are no residual lesions left, then the patients have a very good prognosis. If they have residual lesions after therapy, the prognosis is not as good. We are not sure right now if we should go on treating them or if we should change treatment. This is an ongoing debate and also subject to clinical trials. I guess you have heard about minimal residual disease diagnostic, or you know that we have to do biopsies to prove that there is a complete response. The problem is, in a large trial in France, they compared the imaging findings, in this case PET-CT, with these MRD findings from the pelvis, and they found you can have everything. You can have PET positive and MRD positive. That's not good, obviously. You can have PET negative, but MRD positive, because you just miss it, because the sensitivity is not high enough. But you can also have MRD negative and PET positive, and that's not good, because we tell the patient, you have no minimal disease left, but we have to tell them, if your PET is positive, you have like macroscopic disease left. So this is very important. You can see it can be all over the place. Why is that? This is the spine, and this is the pelvis of a patient, and you can see here such a focal lesion, and if we do our MRD assessment out of this focal lesion, then it's positive. But if we put a needle here, it might be negative. So it's very important to have a combination of both, and they did the same in the trial, and they looked, if you're double negative, meaning MRD is negative and imaging is negative, then it's the best. Then you can see here, this is a very excellent survival. And again, we don't know if we should go on treating a patient with MRD positivity, or we should go on treating a patient with positive PET-CT or MRI after therapy. This is, at the moment, a lot of discussion on this end. The talk about research moving into clinical practice, all of that was developed within the last 20 years. But we go on, we combine PET and MRI to get this information on metabolism, but also on the morphological part. We have this high sensitivity of the MRI. We have this information on the metabolism from the PET. So this is something that is developed right now. We use new techniques, so-called diffusion, I should write it out, diffusion-weighted imaging. This is also based on water molecules, so the content of water. And it's very interesting because water molecules are on a molecular level moving very short distances. But if you have a lot of cells, cells have cell membranes, and those membranes are containing fat. And fat and water, you know, don't really mix. And so if you have a lot of cells, the water molecules cannot move that far because they are restricted by those cell membranes. If you have less cells or destroyed cells, then those water molecules can move further. And a computer can calculate by the movement of the water molecules and the energy they emit. The computer can calculate certain areas where there are a lot of cells and less cells. And a lot of cells can mean, same as inflammation, also malignant processes. And this is how it looks like. This is a patient before therapy, and all those white spots are hypercellular areas where there are plasma cells, and after therapy you see there are still some left, but much, much less. So we use these new techniques, and this has no radiation dose, no contrast agent, so very convenient. It takes about 15 minutes. We usually combine it with the whole body MRI, which is a bit longer, but still we have new techniques which are better with a higher sensitivity and a lower, or in this case even no radiation dose. We also try to use computers to help to identify those lesions, and to a certain degree they can. They can differentiate between good and bad, actually, but this is still part of research. But we are going in this direction to really get an information on the whole body in a very short period of time, because the radiologists usually complain when they have to look at up to 3,000 images in one whole body technique, so they are happy to have some help from the software department. In summary, we can have MGUS, we can have smoldering myeloma, newly diagnosed multiple myeloma, and relapsed refractory, so when the myeloma comes back. And there are several questions we ask. Of course, we always want to know, are there osteolytic lesions, bone destruction? And we want to know that at first diagnosis, because we want to exclude those. If they are there, we want to see how bad they are. We also want to know in the later stages if there are changes in the bone marrow that might lead eventually to osteolytic lesions. We want to know if the spine, for example, is still stable. We want to know if there's cord compression, what I mentioned, the nerves going from the brain to the extremities, if there is anything going on. And we want to know if plasma cells really came out of the bone marrow and grow in the soft tissue. So we use, for the first diagnosis, we use a CT to exclude the osteolytic lesions. We can also do that in follow-up, but if we don't need to, we don't do that. We can also use MRI to see the early changes. In smoldering myeloma, where we know we are a bit nearer to the symptomatic stage, we use mainly MRI. We can also use PET-CT, same for follow-up. Newly diagnosed, it's very important to see the extent of the osteolytic lesions, but we get also information on the functional changes in metabolism, and we have a high sensitivity with the MRI, same in follow-up. And if the disease comes back, because at the first diagnosis, usually the tumor mass or the activity is the highest. Therefore, we rather look at the most important thing, the bone. But in relapse, we know that the disease is there, and we check you every 3 months, for example. Then we know that a lot is going on. So we can use a higher sensitive technique to see earlier when there are changes, because we don't have to prove that there is a myeloma, because we already know it, and we do the same. We can do follow-ups, and MRI, as I mentioned, has the benefit that you don't need a contrast agent and you don't need radiation. And this is what I wanted to tell you about imaging today, and if you have questions, I'm not sure if you do it now or we do it in the round table. Okay, thank you very much.